Here at the Swiss Academy of Ophthalmology in Luzern, I had the great honor to talk to Professor Geoffrey Rose from London. Always a pleasure and always very entertaining. And Professor Rose, you talked about two very different kind of patients, two elderly ladies who had undergone DCR and who had a very different reaction, which is based on two different kinds of mechanisms of obstruction. What is that, and what was your experience with those ladies?
I mean, it was fascinating because they both arrived within about 4 months. There was the little old lady who had a blocked system after surgery, and yet she was delighted, chocolate box positive. And the other lady who had a perfectly open system 4 weeks after surgery, who said, by the way, this is my daughter, who's a medical litigation attorney, and she thought it was a disaster. And yet she was totally open. And that made me realize that there are clearly two different categories here. And what it was effectively was the little old lady who was very happy, despite being blocked, had originally a lot of muckiness because of debris in the tear sac. We'd got rid of all of that problem. And so she was perfectly happy, no longer a sticky eye, even though she was blocked. The other lady had a problem. I make too many tears relative to how fast it can go through the system. She was still making relatively too many tears at 4 weeks after surgery. But given time, the flow through the system, the flow symptoms get better and better. Anything up to about 9 to 12 months after surgery, you can get an improvement. And sure enough, with time, the lady became asymptomatic. The larger-than-life attorney positive lady got better. So there was a lot to learn from that. Volume symptoms, due to the debris in the tear sac washing back, and flow symptoms, as in the other lady. And they can occur together, but if you listen carefully to the patient, you'll hear one predominates over the other.
So once again, listening to the patient's history and symptoms is key to success, however success is defined here.
Absolutely. I have a golden rule. Listen to the patient. For example, in eye socket disease, orbital disease, listen to the patient. They will actually tell you the answer in their symptoms and signs and the history. In about 95% of patients, you'll actually have the answer before you've done the biopsy and so on.
Amazing.
Yeah.
Now, DCR, how successful is it? You were just telling us people have to be patient until the final result is reached. You're an expert. In your hands, how many of these cases are successful? I think it's a high success rate.
Success depends on which symptom you're looking at. So muckiness, where it's due to debris in the tear sac washing back. As soon as you open with the surgery, with DCR, you're opening the sac widely to the nose. So there isn't a dead space to collect all of that gubbins. And so these patients notice an improvement. My eye, following the day following surgery, is no longer mucky. I used to wake up every morning with muckiness because it was stuck like super glue. Open up at surgery, drain everything away, and the patient says, following morning it was no longer mucky. In contrast, the actual flow of tears through the system is affected by the swelling. The canaliculi that join obviously the ocular surface to where you've opened the sac to the nose are very narrow. They're about 0.5 of a millimeter diameter. Any swelling around 0.5 millimeter reduces diameter. And we know that in small caliber systems, if you reduce the diameter by about 10%, which is almost nothing, swelling reduces it much more. If you reduce it 10%, you cut flow by about 1/3. So a little bit of swelling, no wonder the patient's still watering. And that takes a while for the swelling to settle down. I say to the patient, if you broke your ankle or twisted your ankle, it takes 6 to 9 months before that ankle returns to normal function. No different with the swelling in that area. And you will notice with time, most people will get better. So don't panic at 4 to 6 months out. Give them medical treatment, give them reassurance, get them back if they have a problem. And most of them won't come back.
That's good news.
Either they've gone somewhere else or it's truly settled.
That's good news. For our viewers who are not experts or surgeons themselves, what is in your view the basic difference between the external and the endonasal DCR?
The basic difference is with external DCR, if it's done well, in other words, gone through the skin, you have a much wider access and you can make a bigger bone opening, osteotomy. The soft tissue connection cannot be bigger than the bone opening. By definition, it's always smaller. And we know that if you have a small soft tissue opening into the sac, some patients will have residual sac, and that's bad news. It's what I call a bird box rhinostomy, like a small opening, a collection behind it, because that collection will continue washing back into the tear lake, and they'll come back a month or two later and say, my eye is still mucky, my eye is still mucky. You know, I don't want to pay you anymore. And
that's bad news.
So literally, to get rid of that residual compartment, you want to open wide, and you can really only get the maximum opening through an external incision. Endonasal, there is more restriction, but it is interesting. If you look back 30 years to endonasal, 35 years, people were making small openings with laser, and they said, that's enough, it'll flow. It wasn't enough. The number of redo surgeries I've had to do on patients who've had small rhinostomies, be it laser or endonasal, and it's always the same problem. You find the residual sac, you open it properly, cured. But the trouble with endonasal, especially in the early days, people thought small opening was enough. At the lower end of the sac, they say it'll flow out. It doesn't.
Size matters.
Tears, correct. Very true. They, you know, tears are not. People think of them as liquid. They're actually quite viscous, you know, quite gooey, and so you don't get free flow through a small opening. And the endonasal surgeons have come to realize this from the external surgeons. To improve their rates, which had a high failure rate due to the small opening, they realized we've got to take out a lot more, get the sac much more widely open, and try and keep it open as much as possible. But however good they are, they will not end up with the same opening that I can get by removing more bone, when I can get the sac literally open like a book. That's my mentor taught me that 40 plus years ago. You want it open like a book, because then it'll remain open like a recess rather than a small opening. So I'm not anti-endonasal DCR, far from it. I just know that I can get 100% success for volume problems. I can always eliminate the compartment. I cannot always cure watering. And I know that with endonasal, you'll never get as big an opening. They're working towards it and they're doing better, but they'll never be as good. And so if I was on a desert island, what would I want? The best would be a well-done external, somebody who really knows how to get the sac open. The second best would be a well-done endonasal, where they really maximize it. The third best is a badly done external, where they haven't made enough of an opening. And the worst of all is a badly done endonasal. So I know the order in which I would like it done.
That's quite a ranking. Just last question to go back to your keynote lecture this morning. You gave us a view of tear ducts, not just in humans, but also in other species.
Yes.
What is so different about, you know, the other animals like cows and horses and ourselves, tear duct-wise?
Well, there isn't. I mean, the whole thing about looking at the other animals was, why do we have a nasolacrimal duct in the first place? Why has evolution allowed us to have the tears go in at that level and come out at that level in the nose, rather than straight through? Because that's what we're doing with DCR, opening it straight through. So evolution tends to get rid of things that are redundant. If you look at branches of evolution, they actually drop out. And yet, for some reason, nasolacrimal duct has persisted in humans. So I thought, this could be because you have a hydrostatic column, you know, because it is a vertical column. Why doesn't it run forward? Why doesn't it run backwards? It runs vertically, almost perfectly vertically. So I thought, what about dinosaurs? What about cows? What about sheep and other animals that have their head in a dependent fashion? And sure enough, you look at horses, cattle, sheep, rabbits, their nasolacrimal duct, they don't need it long as well. I mean, we're talking 20 centimeters long in a horse. You don't need a 20 centimeter nasolacrimal duct. It could have gone straight through from the eye surface to the nose, and yet the horse retains it and the cow retains it. But its orientation, it runs right from the eye of a horse, right to the tip of the nose, so that when it's down, and same in cattle. So my suspicion has been it's to maintain height of a column of water, which increases the draw through the system due to a hydrostatic effect. And that is useful because wherever you're passing fluid through to an airspace, the nose, you get a surface tension effect. And that surface tension has to be overcome to allow flow of tears. And so it may be that extra weight of hydrostatic helps it through. And maybe doing DCR, where we get rid of that column, is the wrong operation for watering. Not very cheerful when I've done about 8,000 DCRs in 35 years, you know, but that's life.
What an amazing record, and what an honor to talk to you, and a pleasure.
It's a pleasure. Thank you so much.
Thank you.
Thanks.